All right, we'll get started with session 2. So it's my pleasure to introduce Dr. Alex Opitz, who's going to be leading the session. Dr. Opitz is a associate professor of biomedical engineering at the University of Minnesota. So.
Thanks, Matt. I know we are the last session before lunch break, so I'll try to somewhat stay in time. So it's a great pleasure to introduce the session. We'll be focused on neuromodulation for mental health, in particular. Transcranial magnetic stimulation is really like a growing neuromodulation technology for mental health application, and so we'll have 3 science talks, and then it's a pleasure to introduce our first speaker, Dr. Joshua Brown, who's an assistant professor at Harvard Medical School, is an editor-in-chief of a new journal, Transcranial magnetic stimulation. So if you have a study pitch to him, I guess you can do that in the break. And he's also president-elect of the Clinical TMS Society. So I'm really excited to have him here because also his research really kind of spans from trying to understand the basic mechanism of TMS all the way to clinical application. So looking forward to your talk.
Thank you so much, Alex. Okay, good. That's sufficient. So first, I want to thank Megan for that introduction to TMS. I actually didn't put much of an introduction in here because I figured this was a neuromodulation audience and people would kind of be familiar. I was just going to maybe touch on it briefly, but that was a much better introduction than I could have given, so that's fantastic, and very much appreciate and I'm honored by the invitation by Alex to come. I've never been to the University of Minnesota before, and that's a shame because for those that are maybe on the trainee level or kind of getting introduced to the field, University of Minnesota actually is a powerhouse in the neuromodulation space. I would say one of the world leaders with a lot of leaders here. So anyway, it's really great to be here. And what I'm going to do today is sort of unpack this mechanism word a little bit with you, and hopefully things become more clear than less clear. And unfortunately, I don't have to go too much into the TMS sort of where we're at now, but we'll have a little bit of comparison of essentially the main goal. The reason we're not all just kicking back now and just delivering TMS as it is because we think we can make it better, and that's the purpose of this journal that was just started last year. So we have a lot of discounts and free waivers, please, especially in these early parts, just started last August. So very much encourage you to look at the website and send us your submissions, and I'm happy to talk about that. So essentially, a lot of times I'll kind of start with sort of the bottom level and sort of build up to the clinical level. This is going in reverse, where I want to talk about what we already see and then dig in a little bit into how. And so first we'll talk about the clinical relevance and like why do we even care about this term synaptic plasticity that we'll talk about, and then drill down a little bit into how and look at the evidence for this, and then what we can do with this going forward. So that's going to be the goal today. So this is sort of this is the state of the art, I would say, of where we're at. So Alex McGurr, University of Calgary, did this trial, added D-cycloserine, which is an NMDA receptor partial agonist, and we'll talk about that more, 2 weeks of this, and then gave another 2 weeks of just TMS. And you can see these results compared to the standard of care, intermittent theta burst stimulation is the ITBS acronym. Huge effect. And just to give you some sense of comparison, this other graph on the right is from the pivotal trial that led to FDA clearance. And these both use the MADRS scale. And if we bring these over, this is the relative effect. Really importantly, again, this was only 2 weeks of D-cycloserine and 4 weeks total of TMS. For clinical folks, a lot of times patients will ask, when do I start to notice an effect? And usually about average is around 20 sessions is when people first start to notice an effect, not having this full effect. So this was pretty impactful. What if so Alex gave 2 weeks of D-cycloserine for fear of flipping into like a homeostatic depression. Then he moved to this open label trial, did 4 weeks, found 75% remission, so no longer depressed. If we compare that to, again, this idea of 4 weeks or 6 weeks of TMS, these are the data that we usually will cite to patients. When we talk about how effective it is, usually we'll say 50 to 60% response, maybe half of those remit. And that's what these data show, both kind of earlier and more recent from a really large data set. So this is 30%-ish compared to 75% remission. So this is the impact. And then moving over to a different diagnosis, aside from depression, this was using the same approach with OCD, and you can see these really large effects when you combine the ITBS with D-cycloserine. And then this is compared to the seminal or the pivotal trial for OCD. And again, the same Y-box scale, we can kind of compare and see sort of where these land. Obviously, we can't directly compare them. They were the same study, but just to kind of give a frame of reference for how impactful this is. So I wanted to kind of emphasize that. And some that are familiar with TMS, like, yeah, like this is really effective, but we've also learned that there's this other approach that's quite effective, which is giving more sessions. And so these are two naturalistic studies that basically after people got a full course of TMS, they kept giving them, and full course in the United States is 36 sessions because that's what insurance covers. There's background and explanation for that, but this essentially shows that as we keep giving sessions, people will keep getting better. So these are people that didn't respond and that are then starting to respond. And you can see kind of the, what we would essentially expect to be the cumulative in blue, the cumulative response and remission rates. And so we're pushing things higher up on this dose response curve. Like we haven't exactly known how far we can push it. There's this, it's somewhat new still, but it's very well known. Probably, maybe arguably like the best thing known in TMS is the SAINT protocol. So Nolan Williams had this idea of like, why don't we push it higher up and see how far we can go on this dose response curve, and they, as you can see, had really strong results. If you compare those to the naturalistic stuff that we're showing here, they're kind of on the same page. So we're getting to this 70% response, 50% remission sort of range, and the blue is from their open label study. It's not the data shown here. In their open label study, they showed the same, roughly the same area around 1 month. But again, comparing that to, just keeping that in your mind, Alex's study, after only 20 sessions instead of 50 sessions, was 75% remission. So, how to conceptualize this? Like, what do we learn from this? I would say, arguably, and I hope I don't make any enemies, but I'd say that these are probably the two things that have really substantially pushed the envelope in terms of how we can get people better. I'm personally hopeful that there's other ways that we'll do this as well, and Yvonne will talk about, I think, some promising things in this regard with, really sophisticated things like closed loop and things like that. And so there is a lot of potential for more improvements, but I'd say that, in my opinion, these are the two things that have probably really pushed things. And so what we learned from this more sessions is it's kind of like, putting the pedal to the metal, like pushing down on the gas all the way to the floor. So even with a 1920s Model T Ford, you can go faster if you push the pedal down. And I think that's kind of what we're getting from that. But what if we want a faster car? What if we actually want to improve the vehicle? We have to know how it works. And so there's a lot of components to a car. This is a new slide that I put in. I often will talk about this, and I decided just to kind of put it into a slide. There's many components of a car, and I'm not a car expert or mechanic or anything, but it's like if if the wheels are optimized, the axles are optimized, all this stuff, like you might be able to get a little bit more efficiency out of it, but it's not going to substantially make the car faster. Even if you took that 2025 axle and you put it in the 1920s Model T, it's not really going to make that much difference. So what does is the engine. So this is the thing that we need to understand. Like this is the rate limiting driving mechanism. And so what is that in our terms? Like this is how does TMS affect the brain? And so that's kind of the whole basis of my research. And to put this into context, we know that network changes are associated with behavioral changes. We know that dendritic and morphology changes underlie these things, and that synaptic changes underlie those. And DNA and protein, these aren't typically just generated and then sent all of the synapses. They're directed to synapses with activity. That's how we learn. That's how we remember. So this is my whole background and training was in synaptic plasticity. So I admit a bias towards this angle, but I think that there's evidence that it's proving kind of bearing out a little bit. So just a quick background on synaptic plasticity. We have these AMPA receptors. In this review is written for basically people that are not experts. We talk about synaptic plasticity a lot, and kind of what I found over and over is people would be like, I don't exactly know what that is, but I know it's important or something like that. So this was the goal of trying to kind of make that tangible. And we have a little allegory or analogy in it where we talk about, for those of you that are in the medical field, these are like the medical residents. In our residency in neurology, psychiatry as well, we basically did almost all the work. Attendings would kind of sit back, come in, check the box, certify. You can maybe say the same thing for postdocs in a lab. The PI kind of just, give you some edits and so forth here. So most of the work is through these AMP receptors. So whether they're there or not, that's what controls the sensitivity of a response. And so we know with LTP protocols, low frequency stimulation will lead to removal of these AMP receptors. High frequency leads to insertion of these AMP receptors. And so what in this case, and we think this may be kind of applying to TMS, and there's lots of nuances there, but we'll touch a bit on those. So if we add this D-cycloserine molecule, it helps hold the NMDA receptor open more. You have more calcium flowing through, more AMP receptors delivered, which leads to changes like spine size and morphology and so forth. So, is this really specific to synaptic plasticity, or could this be, some people actually said, I always knew that TMS was better with medications, right? And is that the idea? We can just kind of give any medication with this. And this is a review that summarizes all the literature on trials with pharmacologic augmentation of TMS. And of course, the focus here was on D-cycloserine and the NMDA receptor. There's only one other clinical trial. Most of these were done with motor evoked potentials as a synaptic plasticity sort of indirect metric that I'll show something from as well. But these are, this was another trial that was done, actually an antidepressant that works on, it's an SNRI, serotonin noradrenergic reuptake inhibitor, venlafaxine or Effexor. So this was the other trial essentially that's been done, and as you can see, there was no additive effect. No, the combination was no better, and you can see they're quite in line with one another. So I think what we understand from this is that not just anything, and we kind of see this clinically as well. There's not a clear signal of any medication making things better or worse. There's a few hints of things that sometimes replicate, but nothing that's really strong. So no. So we showed Alex's data in the clinical trials, but it doesn't necessarily mean, this is where we're kind of dig down a little bit, it doesn't necessarily mean that it's through synaptic plasticity. It's consistent with that, but it didn't actually test anything with that directly. So we did motor evoked potentials. It's an indirect measure, motor cortical excitability. We look at these MEPs, motor evoked potentials before and after we do this protocol where we have drug on board and we're modulating the receptors. Excuse me. And so we thought, okay, if we can increase NMDA receptor activity, can we increase our motor evoked potentials? So we do this protocol. We do a few time points after. We see the typical, in the placebo condition, we see the typical increase that we would expect to see. This is our TMS-induced plasticity. And then with the D-cycloserine group, we get this additional, this LTP-specific enhancement. And so I say specific because so NMDA receptor activation is sufficient to enhance plasticity. There's a lot of things that are necessary for plasticity, kind of like a car, right? The car analogy. If you take away the axle, the car is not going to go very fast at all. In fact, it's not going to move. But adding more axles or adding a better axle is not necessarily going to be specific. It's not going to add to the speed of it. So this is some evidence for that. And there's some additional evidences that just for time, I'll just kind of summarize here by word. So we see two of these phenomena that we get with LTP: occlusion, which is like a saturation effect. Once you induce it, you can't keep going higher, kind of a ceiling effect. And then another is homeostatic depression. As you push up these synapses in one area, the neuron wants to kind of scale things down so that it stays in this scalable area, and you can continue to learn and continue to modulate. And so we see some evidence. This is, these are indirect, and these really need to be fleshed out in animal models to know for sure. But these are kind of how we're interpreting these. We saw that motor learning augments these effects, and then we see that a real hallmark is that they're NMDA receptor mediated and that they're enduring. So these are some of the evidences that we found in this way in humans. Andres Vlacho's collaborator in Germany, this is what I would consider the most direct evidence that TMS works through LTP, and that's, in mouse hippocampal slices, looked at these, and all the hallmark things that we look for with LTP experiments, he saw. So these increased AMP receptor-mediated currents, these increased GLUA1 receptors are specific to LTP-like increase, and the DAP5 is a NMDA receptor blocker. And so the increase seen with TMS was blocked with that. And I'll clarify that it was slices, so he uses just MS, magnetic stimulation. However, so he found this LTP evidence, but the same protocol actually also reduced GABA receptors, right? So this is cutting the brake, which means there's less inhibition, and so you can get increased excitability from this as well. And so they found, again, the same hallmarks of this, less GABA receptor currents, less GABA receptors. So that was one of the things that we wanted to investigate, because there's pretty big implications. Like, if we're sort of going down the wrong road or the wrong lane with this, we need to course correct. We want to understand, what actually is going on in these synapses here. And so we did an experiment. We did, essentially 8 arms, but 4 arms in 2 different protocols, where we have GABA, we have NMDA, and we have an NMDA receptor blocker. And so in this one, we used, in our ITBS protocol, we have our D-cycloserine in orange, which you can see this, this large increase. When we add to that, so it actually still has D-cycloserine in it, but to kind of do this knockdown effect, we added dextromethorphan as the DXM, and that essentially, abolishes that increase that we saw down to like a placebo level. And then the lorazepam is a bit of inverse thinking, where if you have a lot of inhibitor, GABAs, a benzodiazepine, in the beginning, right, and then if you're removing receptors that it can act on, the GABA receptors, then you should have an increase after. So we were looking for this increase, and we did not see it. So the increase would indicate that there is a GABA receptor removal. This kind of speaks against that, what Andres found in the mouse slices. We did the same thing with 10 hertz TMS, and this is with actually, the stuff I showed before is with a motor protocol. It's like a much shorter, don't know if that totally bears out, and we could have a whole talk on parameter space. Actually, a lot of talks on parameter space. There's a lot there, but we wanted to use the same thing that's used clinically to understand how it's working, and we essentially found the same overall result. D-cycloserine increased, dextromethorphan essentially knocked that down, and lorazepam was not increased. And then we just wanted to look at the comparison between the ITBS and the 10 hertz. Because this also, we consider them clinically equivalent, but mechanistically we don't have great insight in how they might work. And I put some labels on here to not have to necessarily walk all the way through it. Just highlight the 2 things that we did see is that 10 hertz was higher with D-cycloserine, and it was lower excitability with, in other words, there was still a lot of GABA receptors present with the lorazepam. And the interpretation of this, again, this kind of really needs to be nailed down with animal experiments, and we kind of are making some progress towards that. But we think, my interpretation of this is that ITBS is perhaps a more robust LTP-inducing protocol. And so you may get occlusion when you add D-cycloserine, and there's several experiments actually that I won't go into for time that show this. And when you're adding the lorazepam, the GABA agonist, it may just be the relative increase that we see with the intermittent theta burst. This may just be due to overcompensating for it because of the LTP, the stronger LTP. And another piece of data that I decided not to show is that short intracortical inhibition, SICI, this also did not increase. So this supports that idea. Like when you're specifically focusing on the GABA receptor mediated response, even with that, we did not see an increase. So it kind of supports that hypothesis. So we essentially, and this is like our sort of quick future direction. We have this accelerated TMS, which is sort of like pushing down the gas pedal, brings rapid action, and then we have this increased efficiency with the engine of mechanism guided. What if we combine these? Could we climb to new heights, or do we reach a ceiling effect with these? And we did this experiment where we did 10 sessions. It was essentially the same kind of protocol as the Saint protocol, except for it was just 1 day, and wanted to kind of look at what the plasticity effect was that. And we did motor evoked potentials throughout the day just to kind of look at this excitability, and we saw that actually D-cycloserine was lower than the placebo. So this was interesting. And then we did a clinical scale a week out, and there was no increase from the D-cycloserine. If anything, a slight trend towards a decrease. So there seemed to be this kind of ceiling effect. And if you zero in a little bit on this, after the first session, you can see both of them increased, and then the D-cycloserine group had this sort of homeostatic response or inhibition afterwards. And again, these are insights and clues. It's not definitive because we really have to look at what's going on at receptor levels and so forth. But so this suggested that there may be an occlusion effect here. At the same time that we were working on this, Jonathan Downer from Toronto did this kind of different protocol. It's also 1 day, but used 600 pulses, 20 sessions, shorter gap duration, and found really robust clinical response. This was just open label. They were just doing this in the clinic. And this is 30 people. He said he's got like 100, 120 now, showing a similar result. So this is this really strong effect. Like, how do we sort of reconcile these? I mentioned some of the protocol differences. These parameters, we know that each of these make a difference, at least at the plasticity level. My suspicion is that it may have the most to do with this pulse number, and the reason for that is because Andres and another collaborator, Stefan Vestring, both in Freiburg, Germany, they have shown that lower number of pulses for intermittent theta burst are a weaker LTP-inducing protocol. And Stefan showed that if you add D-cycloserine to a weaker protocol, you get an enhancement. But if you add it to a strong LTP protocol, there is not an enhancement. It's occluded. So these are, some interesting things. There's a lot to kind of sort through, but I actually think, in the next couple of years, we'll go pretty far with this. And I just wanted to show, this is some rat compared to human data that is, really shows us that they use the exact same protocol, exact same outcome measure. And I think this, we're hoping that this can kind of help provide a foundation and a basis for further work. And this is analyzed by my postdoc, Hak-Ju Kim. And again, we showed that there's many different receptors, there's many different parts, that we can focus on. We've really just hit the, kind of the tip of the iceberg or scratched the surface. I would say the sky's the limit, but technically 100% remission is the limit. So my goal is not 100, but it's like 90s. So I don't know, bear with me on that. So anyway, I think we get there by letting mechanism guide the way, and I just want to give all the thanks to my lab and funding sources and collaborators, and thank you so much for your time.
Yeah, thanks so much, Joshua. We do questions at the end. So remember your questions. It's a great pleasure for me to introduce Ivan Alekseichuk. Ivan is assistant professor at Northwestern. He just started his lab. Ivan is also a proud alumni of University of Minnesota. So he did his postdoctoral training in my lab and just got the K99. He started the faculty position. So Ivan really, developing, new technologies, new TMS technologies, also for mental health disorders. And he will present with some of the research he did in my lab and also what he's gonna keep working on in his own lab. Ivan.
Thank you, Alex, for a kind introduction, and Joshua for setting the scene and for giving a great overview on neurochemistry. We now will switch gear to electrophysiology. First, I want to say that, as Alex mentioned, a lot of this work was experimentally done still here in University of Minnesota with funding support from NIH, NSF, and MinDrive Initiative. And we also have our IP on closed-loop TMS EEG. I'll explain a little bit why that was necessary. Anyway, so transcranial magnetic stimulations, at its core is electromagnetic method. It really makes sense to look at specific mechanisms how TMS affects electrophysiology in the brain. Of course, core paradigm for that would be to look at propagation of activation, let's say from primary motor cortex to a hand muscle, so-called motor evoked potential, and 95% of everything we know about TMS comes from that, from stimulation of motor cortex and measuring MAPs. But would be also very interested to know more about, can we record direct brain electrophysiology while we're doing TMS and understand mechanisms like that? The problem there is that TMS is a non-invasive method, which is not a problem, it's actually great, but for science slightly problem, which means that we don't have direct recording from the brain. And if we will go to using EEG to understand brain electrophysiology, then we will find a lot of confounds because TMS also excites muscle, skin, peripheral sensory system. So it's hard to tell which part of response is from the brain, which from other nervous system or muscles, other part of body. To look at that, we had to look at a translational research in non-human primates with invasive electrophysiology. It was pioneered by Nipun Pereira, at the time PhD student, Alex Lab. So we had invasive recording from monkey brain when we applied transcranial brain stimulation, TMS, single pass at different intensities. We want to know which part of the response then will come from actual brain. And we also had a number of controlled conditions, such as we provide just acoustic stimulation or just sensory stimulation using electric pulses in order to control for that. In short, although there was a lot of work done there, we found that early TMS evoked potentials, or TEPs, that happening within first 50 milliseconds, as they record electrophysiologically, the most characteristic for direct brain response, and they demonstrate a dose dependency of a sigmoid shape that we would anticipate from something that affects brain directly. And if you looked at this evoked potentials, let's say upper row, where we provide also acoustic masking to hide acoustical stimulation. On a lower row, we provide sensory masking, so we provide electrical stimulation that kind of mimics the sensations of TMS. And we can see that these early potentials, they still preserved in the brain in all contexts and separated in non-auditory and auditory contexts if we mask them, and they abolished if we provide just acoustic and sensory stimulation, but no actual brain stimulation with TMS. So that gives us a good idea that EEG actually can be used to meaningfully capture responses of the brain and quantify what's happening there, particularly early responses. And with that, I want to switch gears a little bit and talk about brain state dependency. So human brain and mammal brain experienced fluctuations of the brain states that can be characterized in multiple time scales using different methods, starting from neurochemical to cognitive, but we're particularly interested in electrophysiological. In the world of EEG, that is most often characterized as brain oscillations. So the question is, does the brain state plays role in how stimulation affects the brain? And can we therefore improve the brain stimulation if we tailor it to the individual dynamic, to the brain state, using closed loop approaches? So the rest of my talk will be about that. And first, if you want to do that, it's important to methodologically do it right. And there is a challenge if you want to be non-invasive while delivering TMS and recording brain electrophysiology, besides the one that I described before, is that you cannot be true real-time operator. And by that, what I mean is that brain signals recorded using EEG or any other non-invasive methods, they're rather noisy. You have to apply a lot of post-processing in order to extract information of interest. At minimum, you need to bandpass filter to extract the band of your interest, such as classical EEG band, delta, theta, alpha, beta. You may need to apply some other methods in order to make your signal cleaner. All of them come with computational costs, so that are not zero, which means that if you apply them, you're always slightly behind in time to your relative, to a true position. From there, you need to catch up using some methods of forward prediction or in some way propagate information forward in time. And that is the point where most of different methods and approaches diverge of how you can do the forward prediction of oscillatory signal. And when we started looking into that, the most standard methods on the field would be to use autoregressive modeling or to just extract peak power of existing signal using Fourier transformation. And with this information now in phase, just propagate it forward. Unfortunately, when we did our internal testing, we found out that none of these methods work well. And on the slide on the right, on the right, you can see 3 columns with 3 different methods, FFT, AR, and the one that we eventually introduced, ETP, Educated Temporal Predictor. And the performance of this algorithm, that is how often pulses that are sent to be at exactly peak of oscillation arrive at a peak of oscillation. Peak oscillation would be 0 degrees. So ideally, you would want to see all the bars turned to the right side. But you can see that there is some variance here, and this is due to the fact that brain signals are very non-stationary. There's a lot of immediate noise, muscle activity, and methods that assume a lot of stationarity struggle to do that. So we had to create our own method, that's ETP here. As you can see, it performed better in all the brain regions that we consider, which is occipital cortex, motor cortex, M1, and prefrontal cortex, PFC. And we later expanded that in order to be able to stimulate any frequency bands in any brain region at any target phase, and whether it's a single pulse or pattern stimulation. So with this method, we came back to this classical paradigm of inducing motor evoked potentials in humans by stimulating motor cortex and recording motor activity from muscle. And we did that while applying stimulation pulses at a specific phase, peak, trough, rising or falling, of 2 different brain oscillations that are characteristic to motor cortex and known to reflected activity, that is alpha or mu. It's the same thing in motor cortex, and beta oscillations. This slide can be very confusing, but left and right side shows exactly the same information. It's just on the left side, it's a more classical representation. On the right, it's a polar representation that gives you better appreciation of the fact that phase is periodic. And here we have normalized motor evoked potentials to average amplitude of motor evoked potentials seen at not state-controlled stimulation. And we can see that both for mu and for beta oscillation, when we apply stimulations there, motor evoked potentials amplitude actually changed if we do it in a state-controlled fashion. For a mu rhythm, we have stronger motor evoked potentials if they apply at a rising and peak phase of mu rhythm, lower otherwise, and for beta rhythm, actually opposite of that. So 2 different brain oscillations differently reflect state of the specific brain areas. And this reflection is functionally meaningful. So for exactly same type of input, we see stronger or weaker output, which tells us that maybe TMS need to be indeed applied in such a fashion. We also looked at power of this oscillation just before the stimulation and saw that in a mu band, also higher power before the stimulation was predictive of a stronger response here on the top. For beta oscillation, we didn't saw such an effect. Well, now we also can take a look at exactly the same data, but now see, can we extract information from the brain directly that captures state-controlled TMS? And we can look at TMS evoked potentials here. And in this case, we saw that at TMS evoked potentials, we look at 2 different potentials, early 15 to 50 milliseconds, as we identify that is relevant to direct brain response, or later potentials around 100 milliseconds. And we saw that for phase-specific modulation of a mu rhythm, or brain state-specific modulation of a mu rhythm. We also saw that magnitude of TMS evoked potentials, so brain response, was also dependent on the phase at which we land the stimulation. That was close to the same response as for the motor evoked potential, so as for peripheral nervous system, but not exactly. It was a fall into trough phase, relative trough to rise in phase for motor evoked potentials. And we saw again that pre-stimulation power also contributed to the magnitude of TMS evoked potential, so brain response, particularly, and in this case, both power of mu and a beta rhythm contributed to magnitude of early evoked potentials, and it did it independently. If you looked at the right side on the B panel, at the first group, you will see that responses were stronger when both alpha and beta power were stronger, and then progressively got lower when both powers get lower. So this is very exciting. It tells us that not only brain state definitely matters for how brain responds, both immediately in the brain and functionally, so when the response propagates to the same motor system. And, well, it's probably very complicated. So different brain oscillation reflect different processes that may overlap. We don't know exactly right now what is the best way to quantify brain state. Is it the phase some oscillation? Is it power? Is it both? Is it something third? And we're just scratching the surface of that. But we already want to see if that has like any meaningful clinical application before we go forward. And the first simple, straightforward idea, yet very complicated execution, to look at potential meaningfulness of that is to look at people with abnormal motor functions, such as in patients with chronic subcortical stroke, as well as their age-matched control, and deliver exactly the same thing. So we do single pulse stimulation of motor cortex, and we looked at motor evoked potentials and at brain responses, TMS evoked potentials, and whether they preserve their state specificity in patients with stroke. So here we can see 4 sets of data. On the top row, that would be patients with stroke in affected hemisphere or unaffected hemisphere. On the bottom row will be age-matched control, left or right hemisphere. They don't have affected or unaffected. Overall, you can see that at the level of motor evoked potentials, we still see all the same pattern, the same brain state specificity. But if we looked at individual data, and on the right we see exactly the same data replotted, where each dot represents a single participant, and diameter of the dot represents their functional capabilities. So the larger the dot, the more functionally preserved they are in terms of motor functions. Small dot mean that they have like motor functions, FMA score decreased. And we can see there that patients that have progressively weaker motor functions, although we still can induce motor evoked potentials in them, those are no longer brain state specific, which tell us that this is a potential tool to quantify objectively their neurological state. The same data we looked at brain responses, TMS evoked potentials. And here everything is simpler. So in patients, when we stimulate unaffected hemisphere of patients with a stroke, as well as both hemispheres in healthy patients, we see brain state specific responses as we would normally anticipate. In patient with stroke, in affected hemisphere, there was no state preference in TEP amplitude. So that tells us, that basically matched what we see in motor evoked potentials. Another exciting application, and the idea we want to move forward right now, and that's what I'm working on, is to leverage our understanding of brain state specificity and to push toward existing clinical applications, which currently mental health primarily mental health. FDA is cleared for depression, as we heard today earlier. It's a great tool, and it's very helpful for some people. Unfortunately, there's still a portion of the population that doesn't have such a great response. And besides supplementing therapy with neurochemical agents, we also can consider to do brain state stimulation. We can consider to do both. So as a first approach to that, we wanted to have a sort of a biomarker of whether there is a brain state specific response, let's say in prefrontal cortex, that is targeted in mental health in the same way as we saw it in motor cortex. Maybe that is just a phenomenon of motor cortex that is well better or organized at the level site architecture. Unfortunately, prefrontal cortex doesn't have such a beautiful marker as MAP. So we had to go with the next thing, which is using some sort of affective task in the volunteers, which we embedded into the whole concept of closed-loop TMS. And now we synchronize stimulation with the task trials and with specific phase of a prefrontal theta oscillation. We took theta as its characteristic for prefrontal oscillation and as a ideological basis for a popular clinical protocol that's called theta burst stimulation that is clinically applied patients in depression. So we had here affective task, which is affective approach avoidance task performed by volunteers, where we ask them to approach positive emotions and avoid negative emotions in one type of conditions called congruent, or do it other way around in incongruent. And as a token of emotion here, there was a face that expressed in either happiness or anger. So volunteers have a joystick. They need to approach happy face, avoid angry face, or do it the other way around, while we do our stimulation prefrontal cortex, and we synchronize everything in such a way that every time when there is a peak or a trough of ongoing theta oscillation, we show them the face and we deliver the burst of stimulation. So we did it in a single burst protocol in left DLPFC, and I just want to, colors are not very well represented here. I just want to give a glimpse of what we saw at the level of our biomarker response, so a behavioral response. As I said, we had 2x2 conditions. We have positive emotions and negative emotion that you need to approach or avoid. So the output of this task is essentially reaction time, and you can do a difference. Let's say avoid negative emotions is how fast you avoid negative relative approach negative, and approach positive is how fast you approach positive emotion relative to avoid positive emotions. And we had 4 standard stimulation conditions, which is a baseline, so just a normal behavior, no stimulation. On the very right, we have vertex stimulation, which is stimulation of off-target brain area, if there are such thing as completely off-target brain area. And then we deliver PFC stimulation, either theta peak or theta troughs. And what we saw here that specifically for when volunteers needed to process negative emotions, their performance was much more according to the instruction when they received stimulation at a theta trough in a prefrontal cortex. And that largely matched other research that few other studies that goes in the area where they're interested in theta oscillation, a closed loop in the context of, let's say, memory, as particularly invasive research in context of memory, where they also saw that stimulation of at the theta trough is more beneficial. So all of that gives us hope that maybe a protocol, TMS protocol in depression that will be delivered in exactly the same fashion with all stimulation aligned to, let's say, theta troughs as a marker of a brain state would possibly be more effective. And that's what we are doing right now. And then I want to say thanks again, Opitz and people who are involved in this work, particularly Zina Shrimpur, Miles Vishnevsky, Nipun Pereira. None of them are currently on this recent photo of the lab, but still. and I will be happy to talk to you later or answer your question during the question session.
Quickly introduce the last speaker for the session, Dr. Jiang, who is assistant professor in pediatrics and psychiatry at the University of Iowa. University of Iowa is a neighbor here in Minnesota. A lot of great research on like really studying mechanism, neuromodulation. We're seeing a variety of methods, and I'm really curious, interesting what you're gonna present today, Dr. Jiang.
Hello, everyone. Can you hear me? Yes. Okay, great. It's my first time to be in Minnesota. It's very exciting, and thanks to Alex invitation and kind of introduction. It's a great opportunity for me to be here to present some exciting work my lab is currently doing, particularly focusing on mapping causal cortical-subcortical pathways using multimodal concurrent brain stimulation recording methods in humans. Subcortical regions such as amygdala and hippocampus are deeply located within the medial temporal lobe. They have been implicated in the pathophysiology of a wide range of neuropsychiatric conditions such as the depression, bipolar, anxiety, PTSD, and so on. So they have been the key targets for neuromodulation treatments. Invasive treatments such as the deep brain stimulation allow direct targeting and modulation. However, its invasive nature and the lack of treatment efficacy evidence from large-scale randomized controlled trials have been limited the widespread use. Meanwhile, the TMS represents a non-invasive option that allows a widespread use. However, the precise targeting and modulation of subcortical regions have been challenging. Because as we know that the TMS use the rapid changes of magnetic fields to generate the electric concurrence to stimulate a cortical region beneath the TMS coil. However, it is unclear whether such kind of cortical stimulation can target and influence the subcortical regions, and more importantly, which cortical region we should stimulate in order to target and modulate these deep subcortical regions. Therefore, there's a critical need for us to establish causal cortical-subcortical pathways in order to form the reliable and precise non-invasive targeting and modulation of subcortical regions. Traditionally, brain recordings alone, such as the EEG, fMRI, and MEG, can provide either high spatial and/or temporal resolutions, and also allow mapping of whole brain connectivity between different regions. However, this connectivity just reveal the correlation or correlative relations between two different brain regions. We still don't know how one region can causally influence the other one. Meanwhile, the brain stimulation, such as DBS and TMS, can provide such kind of causal relation. But this causal relation just limits to the between the stimulated region and some specific behaviors. We still don't know, or it is still unclear, whether the behavior change we observed is a direct effect of the stimulated region, or it is the effect of a downstream region influenced by the stimulated region. Moreover, brain stimulation alone largely relies on the directly observable responses. Unlike stimulating a motor area, you can observe immediate hand twist. Stimulating most of regions or higher order regions that are responsible for complex functions such as decision making, emotion regulation, it is very difficult to track the immediate responses. By combining the brain stimulation and brain recording can help overcome these limitations because it allows stimulating a cortical region or one specific region we are interested in and simultaneously recording activity changes in another region, for example, the subcortical region we are interested in. And thus can help to demonstrate whether selective cortical stimulations are capable of exerting causal neural influences in deep subcortical targets we are interested in. Here's an overview of some multimodal concurrent brain stimulation methods we are currently using in my lab. For the targeting purpose, we mainly deliver the single pulses of stimulation either intracranially or non-invasively, and concurrently recording the immediate activity changes in our target region either intracranially or non-invasively. I'll introduce more details about this with representative work we are currently doing. And for modulation purpose, we are mainly using to combine the stimulation with IEG or fMRI to track the relatively longer neural changes in subcortical regions after some repetitive protocols such as 10 Hz or 20 Hz or ITBS stimulations. Next, I will present a cortical-subcortical pathway we are currently interested in, which focuses on the amygdala. And our graduate student, Xianqing Liu, will also present a poster regarding this topic. If you're interested in this, please stop by and we can talk more about it. Previous concurrent TMS fMRI studies have shown that stimulation some prefrontal regions, for example, the anterior DLPOC and posterior DLPOC and rear POC can all induce amygdala responses changes. However, as we know that the TMS delivery is accompanied with the tick sound and also the tapping feeling over the scalp. And also the MI-compatible TMS does not have the sham side to mimic such kind of perceptual effects. So it is unclear whether the response changes in the amygdala we observed is the real effect of the TMS modulation, or it is just the perceptual effects accompanied during TMS delivery. To address this issue, we designed a series of experiments that combine multimodal brain stimulation and recording methods. We started with IES in combination with IEG. We delivered the single pulses of IES to a prefrontal region using the IEG electrodes implanted here and concurrently record the transient activity changes in the amygdala, also using the IEG electrodes implanted in this region in epilepsy patients. Such kind of method provides minimal perceptual effects, so it can ensure us that the recorded activity changes in the amygdala can be more likely the genuine effects of the prefrontal stimulation. To move towards the clinical translatability, we combine the TMS with IEG. We delivered the TMS to the prefrontal region and still concurrently recording the activity changes within the amygdala using the IEG electrodes implanted here in epilepsy patients. Moreover, as we know that the IEG can only be used in epilepsy patients being evaluated for neurosurgery resection. So this motivates us to combine the TMS with a non-invasive brain recording method to complement and map the effects of TMS that can be measured in a broader population. So in the third experiment, we combined the TMS with fMRI and to investigate the neuromodulation effect of prefrontal TMS in the amygdala. In the first experiment that uses the concurrent IES-IEG, we deliver the IES to left DLPFC of epilepsy patients and concurrently recorded the activity changes, immediate activity changes in the amygdala with electrodes implanted within these two areas. As you can see that a certain number of contacts within the amygdala, especially the medial subregional amygdala, represented with the green line, show very evident evoked potentials following the IES to the DLPFC. The group level analysis across the contacts also demonstrate that the evoked potential change shows significant responses following the IES to the DLPFC. As a control condition, we also deliver the IES to the VLPFC, which is a neighboring region of the DLPFC, and concurrently recorded the activity changes within the amygdala. So as you can see that the evoked potentials were not as evident as that you observed in the following the DLPFC IES. And the group level analysis across all contacts also just reviewed a few short-time window within the 100 milliseconds and also in the late time window. Direct contrast between these two conditions, we also observed much stronger, significantly stronger evoked potentials following the IES to the DLPFC as compared to the IES to the VLPFC. And this difference was mainly contributed by the effects observed in the medial subregion of the amygdala. As we know that the DLPFC consists of several different subregions and that were involved in very complex and different brain functions. So we are further interested in whether IES to different subregions of the DLPFC can induce different patterns of evoked potentials in the amygdala. Very surprisingly, we observed that the IES to two posterior DLPFC subregions, the ventral area 8 and also the inferior frontal junction, these two areas can induce very evident evoked potentials in the amygdala, while the IES to the three anterior subregions of the amygdala didn't show similar patterns. Next, with the concurrent TMS IEG, we delivered the single pulses of TMS to the DLPFC of the epilepsy patients and concurrently recorded their immediate responses in the amygdala. We observed very strong evoked potentials following the active TMS to the DLPFC as compared to the sham TMS to the DLPFC. And this effect was also mainly driven by the medial subregion of the amygdala. But of course, that we have fewer sample size for the lateral, so we are still thinking that maybe with more sample size, the pattern may or may not change. As a control condition, we also delivered the single pulses of TMS to the parietal area and concurrently recorded the evoked potential changes within the amygdala. We didn't observe a similar pattern in the amygdala, either following the active TMS or the sham TMS following to the parietal area. Direct contrast of these two conditions, we still observed very strong evoked potentials following TMS, active TMS to the left DLPC as compared to that following TMS to the right parietal. And this effect was mainly driven by was mainly observed within the medial subregion of amygdala again, and there's no significant difference observed in the lateral amygdala. We also compared the evoked potentials following stimulating the different subregions of the amygdala, and we observed very distinct patterns, which is surprising. I think maybe this is partly because the TMS, as mentioned just now, has some perceptual effects when you stimulate in different subregions of the prefrontal area, and it may also because that the TMS is not as focal as the intracranial stimulation. So the electric field covered by the TMS may cover several brain regions that involve in different brain networks, thus inducing different patterns in the downstream area we are interested in. Finally, we use the concurrent TMS fMRI to investigate the effect within the amygdala following TMS to three brain regions, the anterior DLPFC, the posterior DLPFC, and the control region of the right IPL in larger population. Consistent with what I found in my previous study with sample size, the results based on these larger sample size confirmed our hypothesis that the DLPFC TMS can induce amygdala response changes within the amygdala as compared to the TMS to the right IPL. We are further interested in whether the intrinsic connectivity between the stimulation site and amygdala, which was assessed with the resting state fMRI, can explain the different patterns on the TMS evoked responses we observed in amygdala. Very interestingly, we found there was a very significant correlation between the left posterior DLPFC amygdala connectivity and the TMS-induced or evoked responses in the amygdala. Specifically, if there's a strong negative functional connectivity between the posterior DLPFC and amygdala, you will observe a great deactivation in the responses following the TMS to the posterior DLPFC. This was not the case for the stimulation of the anterior DLPFC or stimulation of the control region in IPL. To have a brief summary, so through these three experiments combining multimodal brain stimulation recording methods, we identified definitive and convergent evidence that the amygdala can be targeted by both the invasive and non-invasive stimulations of DLPFC, especially the posterior DLPFC. And the correlation between the individual posterior DLPFC amygdala function connectivity and the posterior DLPFC TMS evoked responses in the amygdala may suggest a very promising personalized functional connectivity guided TMS strategy to help us to identify a DLPFC TMS spot for non-invasive neuromodulation of the amygdala in the future. We also have several ongoing exciting work. One topic we are currently interested in is whether we can expand or extend the DLPFC TMS for amygdala modulation to adolescents. As we know that our human brain matures from birth, it starts from the brain areas responsible for motor and visual area, and then later in prefrontal regions. And DLPFC only starts maturing from adolescence, like here showing around age 12, with excessive gray matter pruning out and white matter connections increasing for more specialized and efficient communications between different regions. With the concurrent IES-IEG, we have identified some preliminary evidence that first, the influence of the DLPOC to the amygdala indeed was weaker before adulthood as compared to the adulthood. And focusing on the different significant time window showing different evoked potentials, and also the pediatric patients we have, we found some more interesting finding. The DLPOC IES evoked potentials in the amygdala reach to the peak at around age 13 and remain stable into the adulthood. So this suggests a great potential for us that DLPOC TMS for amygdala modulation may be feasible, or to start, we can take some early intervention with this method for amygdala modulation. We also have some other ongoing work, and we established the concurrent TMS FMI in Iowa, and so we are investigating the neuromodulation of effect of TMS using the intermittent theta burst stimulation. And hopefully we can discuss this part of findings in the future. Another final ongoing work I would briefly highlight is we are also interested in the pathway for hippocampus modulation. We investigated whether the hippocampal FC-guided parietal TMS can target and induce modulation effect in the hippocampus using the concurrent TMS IEG in epilepsy patients. The answer is yes. We identified that this hippocampal FC-guided parietal stimulation, or TMS, actually induced the stronger evoked potentials in the hippocampus as compared to that without such kind of TMS strategy. We also observed the hippocampal FC-guided active RTMS induced theta inhibition in the hippocampus. This was not the case for the hippocampal FC-guided sham RTMS to the parietal area, neither with the non-hippocampal FC-guided active RTMS to the parietal area. Yeah. So finally, thanks my colleagues from Iowa community and also the collaborators across nationwide, and the funding resources from NIH, Brain and Behavior Research Foundations, and Iowa Carver College of Medicine. Thanks my lovely and hardworking lab members, and thank you for your listening.
Yeah, thanks so much. Thanks so much to all the speakers also being amazingly well in time. So you saved sometimes, so we have like 10 minutes now for questions to the whole panel. I have many questions, but I think, see whether some questions from the audience.
My question is, what is the time duration from the end of the TMS session to the initiation of the fMRI protocol in the targeting protocol of your study?
You mean targeting the cortical region we are interested in? Yeah, so we have a neural navigation system currently. We scan the participants' native T1 first, and then use this T1 to identify the spot we are interested in. And the DLQC currently we're interested in is focusing on the posterior DLQC. We have already identified the evidence that it will target the amygdala.
Thank you for the really great talks. I have questions for two speakers. Yvonne, I wanted to ask you about the theta trough linked stimulation result with the negative avoid RT, that particular result. Do you think that that's specific to an affect or emotional paradigm, or do you think you would see something similar in a Stroop? Is this a cognitive control thing, or is it more specific to, a response, an affective response?
Thank you for the question. Well, first, if it would be like variant specific, we'd probably see it for other type of emotional stimuli. So for positive emotional stimuli, which tells me that it's at least somewhat specific to negative affect. Saying that, I'm aware of, basically yesterday was published a work where researchers were stimulating hippocampus for memory, and they also did closed loop stimulation of theta oscillation there in hippocampus, so completely different brain area paradigm whatsoever. And I think the positive effect memory paradigm was also there related to trough of theta. I don't know much of it. I think it was Joel Force and Alekseichuk, so you can follow up with that. But it seems like it's possible that it's a general cognitive control, but to be honest, in terms of clinical effects, it's like it will not matter for us much of why. Although, again, positive emotional stimuli didn't show such phase dependency, so some specificity is there.
I mean, that's what actually made me think it might be cognitive control, because you can imagine avoiding a negative stimuli is more of a cognitive control like.
Yeah, that's certainly a possibility, yes.
I mean, either way, it's a really fascinating result, yeah. And then for the last speaker, I really loved your talk. I was curious, there's a paper that came out a couple years ago on looking at connectivity between the ventrolateral prefrontal cortex and the amygdala, which doesn't seem completely consistent with some of the results you have, which are really beautiful data. I mean, the result is really clear in your data. So I'm wondering, is this an inter-individual variability thing? Is this like, individuals' connectivity across lateral prefrontal cortex with the amygdala varies enough that you could see the effect depending on where exactly you looked, and did you look at white matter tract connectivity? I mean, just, really curious about your thoughts since your results are really so compelling and clear.
Thank you so much for the question. So that paper is from my friend Desmond. So when we identified that using the IEG data, identified that DLQC is more important to modulate the amygdala, we are also surprising. And I think maybe the first reason is that the amygdala commonly observed, or the amygdala response induced by TMS to different prefrontal regions might be some perceptual effects. So we also have a concurrent TMS-MI study covering stimulation of 11 TMS sites, and we use the PCA to identify the common neural effects induced by the TMS. We identified the lateral amygdala is commonly influenced by the TMS with different stimulation size. And so, but the medial subregion amygdala is still influenced by the posterior DLQC. So that's what I didn't include in the talk, but we are in the preparation of these results. And for the connections, like you mentioned about the white matter tract connections, whether they have some, whether I have some thoughts, and actually we do have some thoughts and have some preliminary data working on it. And so we are also trying to see whether because the DLPOC and the VLPOC both have regulation to a lot of subcortical regions involved in emotion regulation. And we also want to know, for example, whether DLPOC exerts such kind of influence to amygdala through VLPOC, or it's the opposite way. Yeah. And for wild child connections, based on the human connectome data sets, we already identified that there's connections between the DLPOC and amygdala. Yeah.
Great set of presentations, all of them are very, very interesting. I just have a brief question for the last speaker. Sorry, Robert Edmosio at the University of Minnesota. And that's presumably these patients that are going to be undergoing surgery for their epilepsy are taking some sort of anti-epileptic medication. Have you thought about the potential for the change in the resting motor threshold or cortical excitability induced by taking that medication?
Change the resting state connectivity?
Resting state, like motor threshold, or, the resting motor threshold, or like the changes in cortical excitability due to taking anti-epileptic drugs?
Yeah, that's an interesting topic. I have not thought about that, but definitely we can communicate more about this. I'm not familiar with these fields, but yeah.
Thanks.
Thanks.
I feel like I should ask one quick question for Josh. So it was a great talk about the dose finding. So can you stimulate too much? Was my question. I think your last slide almost answered this. So at some point, I had some homeostatic plasticity kicking, and maybe you can elaborate a bit on that.
Yeah. So this idea of occlusion that I talked about and homeostatic plasticity, they're a little bit of kind of on the same paradigm, right? So we know from early studies that if you induce LTP and then you induce it again, like you get a max effect. It's hard to know from the human studies, and there's some paired pulse data that I didn't show, and then the data that I showed there. I think that that's what is happening in those cases, and there's also 2 studies that had previously tried decycloserine with intermittent theta burst. Actually, one clear back in 2007 with John Rothwell's group and then Alex McGreer's group, and they didn't see an increase, and that was kind of my leaning towards the beginning. The stuff that we saw an increase with was 10 hertz, which I think is maybe a weaker protocol, and so I think that there's a lot of the parameter stuff at play, and I think that some of the stuff we see clinically, like it doesn't seem to make a huge difference, some of these parameters, but I think that may change if we start to commonly augment with these pharmacologic adjuncts, because it's like we then start kind of pushing it to the limit, and then I think we might get much more sensitive about what the parameters are that we use. There's a lot to sort through with that, and I think that the animal models, being able to kind of do this in like a higher throughput way, would be really helpful to parse that out. Modeling could also be a very helpful way to do that, in addition to kind of the very slow human studies that we try to do. So yeah, so I definitely think that's in play.
All right, yeah, thanks so much. I think we are right in time. I want to thank all participants of the session, including lived experience speaker, and then I think we'll all go to the well-deserved lunch break. All right, thanks everyone.